This patient had triple coronary artery bypass graft surgery yesterday. Her post-operative recovery has been remarkably stable, and she has been progressing well. But now she's complaining of fluttering in her chest. No heart murmurs are present. The pulse and heart rates are regular. No pulse deficit is present. There has been no change in her hourly urine output, and her arterial blood gas levels do not reveal any significant change. Her arterial blood pressure has dropped from her usual reading of 140/78 to 100/60. Her heart rate has increased slightly, and the rhythm is irregular. The classic sawtooth pattern of atrial flutter is seen on the bedside monitor. Is the development of this dysrhythmia life-threatening to the patient? If not, could the dysrhythmia progress to one that is? Does this dysrhythmia indicate a developing complication? Is immediate intervention necessary? If so, what interventions are appropriate? This program focuses on recognizing commonly encountered dysrhythmias. Beginning with a brief review of the heart's electrical conduction system, it goes on to show the correlation between the EKG waveform and what electrical events are occurring. It also discusses how to analyze an EKG waveform and shows you how to assess complex atrial and ventricular dysrhythmias. Patient examples are used to help you learn cause and effect relationships, which dysrhythmias are potentially life-threatening, and what treatment is needed.
A dysrhythmia can lead to serious complications for the patient. Some may be life-threatening, while others may be well tolerated by the patient, and some may herald the development of even more serious dysrhythmias. Consequently, an accurate assessment of the dysrhythmia is vital. In many patient care situations, it is critical that you correctly identify the dysrhythmia, rapidly evaluate its significance to the patient, provide appropriate interventions when needed, and evaluate the patient's status after treatment. The central station, or bedside EKG monitor and rhythm strip, are valuable tools that can be used to identify dysrhythmias, but they do not take the place of patient assessment. Some dysrhythmias may have little effect on one patient's hemodynamic stability, but may precipitate significant changes in another patient. Let's begin with a review of the electrical conduction system.
The contractile cells of the heart cause the myocardium to contract and relax. This rhythmic sequence of contraction and relaxation maintains blood flow. The myocardial contractile cells must be electrically stimulated before they can contract. Pacemaker cells repetitively initiate electrical impulses, a characteristic referred to as automaticity. These cells are located in the sinoatrial or SA node, the atrial conduction pathways, the atrial ventricular or AV node, the bundle of His, and the Purkinje fibers. The sinoatrial or SA node is the primary pacemaker in the normally functioning heart. It initiates electrical impulses from its location in the right atrium near the entrance of the superior vena cava. Conduction of the impulses to both atria occurs over internodal pathways and results in atrial contraction. Atrial contraction pushes blood into the relaxed ventricles, filling them. The impulses reach the atrioventricular or AV node located at the junction of the atria and ventricles. The AV node slowly transmits the impulses from the atria to the ventricles, allowing time for the atria to contract completely and fill the ventricles with blood. From the AV node, the impulses are rapidly conducted through the common atrioventricular bundle, the bundle of His, which further divides into right and left bundle branches. The left bundle divides into anterior and posterior fascicles. The microscopic Purkinje fibers receive the impulses from the bundle branch fibers and directly stimulate the cells of the ventricular myocardium. The result is a forceful, coordinated contraction of both ventricles and ejection of blood into the pulmonary artery and aorta.
You can easily assess electrical impulse conduction through the heart by carefully examining the EKG waveform. The electrocardiogram, or EKG, reflects the timing, amplitude, and direction of the heart's electrical activity. Remember, the EKG reflects only electrical activity, not mechanical activity. The P wave represents atrial depolarization. The QRS complex represents electrical depolarization of the ventricles. The T wave indicates repolarization of the ventricles. Other parts of the waveform are also important. The PR interval represents the time from the beginning of atrial depolarization to the beginning of ventricular depolarization, when atrial contraction fills the ventricles with blood. The duration of the QRS complex represents the amount of time for ventricular depolarization. The QT interval is an important time measure of ventricular activity. It may be affected by certain types of medications, and when prolonged, may indicate a predisposition to significant heart rhythm disturbances. Now let's look at selected patient examples.
This 25-year-old man had elective orthopedic knee surgery a few hours ago without complications. He is presently hemodynamically stable, which means that blood and oxygen delivery to all body tissues is adequate. His blood pressure is within normal limits. He's conscious and coherent, his urine output has not changed, and his skin is pink, warm and dry. He is resting comfortably and not complaining of any discomfort. But during auscultation, the nurse heard an irregular heart rhythm. She reported this finding to the doctor, who ordered a 12-lead EKG and a rhythm strip. On the strip, the P wave is always present and looks normal. It is positively deflected in lead 2. A QRS complex follows every P wave. The atrial rhythm is irregular because the PP interval is variable, and the atrial rate is about 70. The PR interval is normal and consistent in duration at 0.16 second. The RR interval varies, so the ventricular rhythm is irregular. The ventricular rate is about 70. The QRS complex duration is 0.08 second, within normal limits. And the QT interval is normal, at 0.36 second. The typical periodic heart rate changes in the rhythm is called a sinus arrhythmia, the most common type of cardiac dysrhythmia. It is a benign condition and does not indicate a change in the patient's condition. No treatment is necessary for this dysrhythmia. This 41-year-old patient has a long history of palpitations and rapid heart rates. On admission to the CCU, she appears to be dyspneic, and her respiratory rate is 28. Her heart rate is 154, and her blood pressure is 110/50. She seems extremely apprehensive, but is not complaining of any pain. A baseline rhythm strip is recorded. On the strip, the P wave is present, although it is difficult to see clearly. It appears to be followed by a QRS complex. The atrial rhythm appears to be regular, and the atrial rate is very rapid at 150 beats per minute. The PR interval is 0.16 second. The ventricular rhythm is regular, and the ventricular rate is about 150. The QRS duration is shortened. It is 0.08 second. The QT interval is difficult to assess because the rhythm is so rapid and the end of the T wave is not clearly seen. This dysrhythmia is paroxysmal atrial tachycardia, or PAT. It is sometimes called paroxysmal supraventricular tachycardia, or PSVT. The rhythm is atrial in origin because P waves are present and the QRS complex is not widened. A rate of 150 to 250 beats per minute is typical. PAT is associated with coronary artery disease, rheumatic mitral valve disease, and thyrotoxicosis. It can be a serious dysrhythmia because it may lead to reduced cardiac output and heart failure, particularly in patients with cardiac disease. This decompensation occurs because the atria and ventricles do not have sufficient time to fill. Even patients with healthy hearts may develop heart failure if the PAT persists. Consequently, immediate treatment is recommended if the dysrhythmia does not resolve spontaneously. Vagal stimulation may successfully convert the abnormal rhythm to a normal one. Valsalva's maneuver is often used. To perform this maneuver, the patient is instructed to strain, as if having a bowel movement, and to simultaneously exhale against a closed glottis. Other interventions include providing rest and reassurance, administering medications to sedate the patient, and administering medications that either slow electrical conduction through the heart, such as verapamil hydrochloride, digoxin, or propranolol hydrochloride, or that elevate the blood pressure, such as metaraminol bitartrate or phenylephrine hydrochloride. Cholinergic medications, such as edrophonium chloride, may also be ordered to increase vagal tone, which slows AV conduction. The choice of medications depends on the patient's underlying cardiac condition, on other medications that the patient is using, and on his clinical status. This patient, described at the beginning of the program, developed a dysrhythmia 1 day after triple coronary artery bypass graft surgery. The distinctive sawtooth waveform pattern of atrial flutter was seen on the monitor. Analysis of a rhythm strip confirmed the dysrhythmia. Normal P waves are not present. Instead, sawtooth-shaped F waves, or flutter waves, are noted. The ratio of F waves to QRS complexes is variable, from 2:1 to 6:1. The atrial rhythm is regular because the F waves are regular. The atrial rate is about 370. The PR interval cannot be measured. The ventricular rhythm is irregular, and the ventricular rate is about 80 beats per minute, which is less than 1/4 of the atrial rate. The QRS complex duration is 0.08 second. The QT interval can't be measured because the T waves are not clearly seen. The development of atrial flutter in this patient may be caused by inflammation, which normally occurs during healing, or it may result from fluid overload and dilatation of the atria. In other patients, it may be associated with sick sinus syndrome, hyperthyroidism, hypoxia, pericarditis, or valvular heart disease. It is a serious dysrhythmia. The changes in the patient's status are probably directly related to the atrial flutter rhythm and the resulting reduction in cardiac output. The dysrhythmia is produced by the very rapid but regular firing of the SA node. An atrial rate of between 220 and 350 beats per minute is common. Since the AV node cannot conduct impulses this rapidly, the ventricular rate is usually only 1/2 to 1/4 of the atrial rate. Suspect atrial flutter in a patient with narrow QRS complex tachycardia at a ventricular rate of about 150 beats per minute. The type of intervention depends upon the patient's clinical status and signs and symptoms. If the patient is not hemodynamically compromised, medications to slow the ventricular rate, such as digitalis, verapamil hydrochloride, or beta-blocking agents may be given. After the rate is controlled, an antiarrhythmic such as quinidine gluconate or procainamide hydrochloride is ordered to try to convert the flutter rhythm to a sinus rhythm. If these interventions do not convert the flutter rhythm, then synchronized cardioversion is used. This 50-year-old man has a long history of alcoholism. He has come to the emergency department complaining of heart palpitations and dizziness. His apical heart rate is very rapid and irregular. His radial pulse rate is also rapid and irregular. His blood pressure is 96/64, and peripheral perfusion is decreased. A baseline rhythm strip reveals the following information. A typical upright P wave is not present. Although narrow QRS complexes are seen, a P-QRS relationship cannot be established. Some discernible F waves are seen. They vary in size and shape and have an irregular rhythm. Consequently, and atrial rhythm and rate cannot be measured. The PR interval also cannot be measured. The ventricular rhythm is irregular, and the ventricular rate is 100. The QRS complex duration is 0.08 second. It is impossible to accurately measure the QT interval. This dysrhythmia is atrial fibrillation. It represents random chaotic electrical discharges in the atria between 350 and 600 times per minute. Because electrical impulses reach the AV node randomly, the ventricular response is very irregular. Because cardiac output is significantly decreased by at least 20%, atrial fibrillation is considered to be a serious dysrhythmia, especially in patients with decreased cardiac output. The immediate treatment goal is to slow the rapid ventricular rate. This is usually done by administering drugs that slow AV conduction, such as digitalis, verapamil hydrochloride, or beta-blocking drugs. However, synchronized cardioversion may be the treatment of choice, especially if the patient is hemodynamically unstable, in severe congestive heart failure, or experiencing angina caused by the rapid heart rate. The chances of a successful conversion to a normal sinus rhythm depends on atrial size and the length of time the patient has had atrial fibrillation. The more dilated the atria and the longer the patient has been in atrial fibrillation, the less likely that a successful conversion will occur. An additional risk of atrial fibrillation occurs when thrombi develop in the atria because of blood stasis. If the thrombi dislodge, pulmonic or systemic embolization can occur. Anticoagulant therapy to prevent emboli may also be started if conversion to normal sinus rhythm is delayed. This 42-year-old woman just came to the post-anesthesia recovery room 5 minutes ago after having a hysterectomy. She is not fully awake and is still intubated, but breathing spontaneously. She's receiving oxygen and is being monitored because a dysrhythmia was noted during surgery. Her vital signs are stable. Her blood pressure is 108/62. Her apical heart rate is 64, and her respiratory rate is 14. The nurse runs a baseline rhythm strip. On the strip, the P wave is present and normal in appearance in lead 2. A QRS complex follows each P wave. The atrial rhythm is regular, but the rate is slow at 50. The PR interval is prolonged, 0.24 second, but it is constant in duration. The ventricular rhythm is regular. The ventricular rate is 50 beats per minute. The QRS complex duration is 0.12 second, and the QT interval is 0.40 second. These findings indicate a first-degree AV block. This occurs because electrical conduction through the AV node is delayed, which is indicated by PR intervals of greater than 0.20 second. First-degree AV block can develop in people with healthy hearts, or in people whose hearts have been damaged by ischemia, infection, rheumatic fever, or drugs. This dysrhythmia probably resulted from the anesthesia administered during surgery. No doubt it will resolve spontaneously as the anesthesia effects wear off. However, the patient must be monitored closely during her recovery. If her heart rate drops below 40 beats per minute, or her blood pressure becomes abnormally low because of the low heart rate, the doctor will probably order IV atropine sulfate, 0.5 milligram, to block the effects of increased vagal tone. This 18-year-old patient has just been admitted to the hospital, complaining of a fever and headache that have been present for a week, and abdominal pain. The assessment reveals an erythematous rash and pharyngitis. During palpation, she also complains of several painful joints. Her admitting diagnosis is probable acute rheumatic fever. The doctor orders a routine 12-lead EKG. On the 12-lead, the shape of the P wave appears normal for the most part. However, not every P wave is followed by a QRS complex. The atrial rhythm is regular. and the atrial rate is 60. The PR interval becomes progressively longer until a P wave appears that is not followed by a QRS complex. The ventricular rhythm is irregular. The ventricular rate is about 40 beats per minute, which is less than the atrial rate. The QRS complex duration is 0.12 second. The QT interval is 0.34 second. A diagnosis of second-degree AV block has been made by the cardiologist. This type of second-degree block is called Mobitz type 1, or Winkebach. This dysrhythmia occurs when conduction time through the AV node becomes progressively longer, which explains why the PR interval becomes progressively longer. When the PR interval becomes excessively prolonged, no ventricular depolarization occurs. This patient's dysrhythmia is a direct result of heart tissue inflammation associated with acute rheumatic fever. Winkebach AV block can also accompany acute inferior myocardial infarction or digitalis intoxication. The patient must be monitored continuously for changes in the dysrhythmia because this rhythm can occasionally progress to complete AV block. As long as her heart rate remains above 60 and she remains hemodynamically stable, treatment is probably unnecessary. However, if her heart rate drops or if Mobitz type 2 AV block develops, treatment is essential. This 76-year-old man has chronic congestive heart failure. He was admitted 3 days ago with acute pulmonary edema. He was started on digitalis to improve cardiac output. The nurse notes that the patient is restless and somewhat diaphoretic. His blood pressure has dropped and his urine output has decreased. His heart rate is down to 54 beats per minute. A 12-lead EKG is ordered by the doctor. The P waves appear to be normal, although in some leads they are difficult to identify. Not every wave is followed by a QRS complex. The atrial rhythm is regular. The atrial rate is about 60. The PR interval at 0.28 second is prolonged but constant. Typically, the ventricular rhythm is regularly irregular because the P waves occur at regular intervals and the PR interval remains constant. The ventricular rate is about 40, less than the atrial rate, because dropped beats are occurring. The QRS complex duration is 0.06 second, and the QT interval is 0.36 second. This is a Mobitz type 2 AV block. The block is occurring in the AV node, but it may also occur below the bundle of His. It is a serious dysrhythmia because it may progress to third-degree AV block. The nurse suspects the cause may be digitalis toxicity, possibly because of poor renal clearance. But the block could also be caused by worsened myocardial disease. The nurse receives orders to hold the digitalis and give atropine sulfate 0.5 milligram by IV push. If needed, she may start an IV isoproterenol hydrochloride infusion. She is to run a 12-lead EKG and have blood drawn for STAT enzyme levels and a serum digitalis level. The patient is now complaining of substernal chest pain, a symptom of decreased myocardial perfusion, and the patient also has signs of decreased cardiac output. His blood pressure has dropped to 90/60, and his heart rate is down to 46. The nurse gives IV atropine and runs another rhythm strip. The rhythm strip shows P waves are present, but there appears to be no relationship between the P waves and QRS complexes. The atrial rhythm is slightly irregular. This is probably because of a sinus dysrhythmia. The atrial rate is 110. The PR intervals vary with every beat. The ventricular rhythm is irregular. The ventricular rate is about 50 beats per minute. The QRS complex duration is 0.08 second, and the QT interval is 0.44 second. ST elevation indicating myocardial ischemia is also noted. The patient has now developed a third-degree AV block, a life-threatening dysrhythmia. The ventricles are not receiving any electrical impulses from the atria. Electrical impulses originating from the AV node or bundle of His are causing the ventricles to depolarize at a rate that is considerably slower than that of the normal SA node. Because the atria and the ventricles are depolarizing and contracting independently of each other, cardiac output is significantly compromised. This is an emergency situation. Immediate interventions include starting an IV isoproterenol hydrochloride infusion and arranging for a temporary pacemaker insertion.
Look, I just don't have that information. Well, that's the office. I'll have to get back with you. Okay, yeah, just soon as possible.
This 58-year-old man is one day post-op after a transurethral resection. He's had hypertension for over 15 years and takes medication regularly to control his blood pressure. 2 years ago, he had a myocardial infarction. Despite his health problems, he has made no attempt to change his lifestyle. As a stockbroker, his work is high-pressured and he's currently experiencing a considerable amount of emotional stress. The patient is now complaining that his heart feels like it is flip-flopping. As the nurse examines his 12-lead EKG, she notes that some waveforms do not have a P wave. The duration of some QRS complexes is greater than 0.12 second. These widened complexes are not preceded by a P wave, are early, and they have a bizarre appearance when compared to the normal sinus beats. The deflection of the QRS complex is opposite that of the normal sinus beats. The bizarre widened complexes are premature ventricular contractions, or PVCs. These PVCs are initiated by a single ectopic focus in one of the ventricles. Normally, PVCs occur occasionally in healthy people. However, coronary artery disease and certain drugs can cause PVCs. Their underlying pathology, the frequency of occurrence, and the associated signs and symptoms determine the need for treatment, because PVCs can precede even more dangerous and possibly fatal dysrhythmias. Immediate intervention is required if the patient is experiencing acute ischemia or an acute myocardial infarction, or if the PVCs occur more than 6 times a minute. IV lidocaine hydrochloride, administered first as a bolus, then by IV infusion, is the recommended treatment. If hypokalemia or hypoxia have developed, they must also be corrected. Atropine sulfate may also be given IV push if the heart rate is low. Some PVCs are characterized by a compensatory pause that occurs after the PVC and before the next normal sinus beat. PVCs may also appear in pairs called couplets. Couplets are more serious than isolated PVCs and may require treatment with IV lidocaine if the patient is symptomatic, especially in the patient with acute ischemia or infarction. Multiformed or multifocal PVCs may also develop. The morphology of each is different because they originate from different ventricular ectopic sites. Multifocal PVCs are serious because they often progress to ventricular tachycardia or ventricular fibrillation, especially in patients with acute ischemia. Treatment must be immediate. A bolus of lidocaine hydrochloride followed by an IV infusion of the same drug is recommended. This 62-year-old man was admitted to the ICU 2 days ago with chronic obstructive pulmonary disease and respiratory failure. He has been in acute distress since admission. He has hypokalemia and has also developed mild congestive heart failure. The monitor shows multiple PVCs despite lidocaine and potassium replacement. Suddenly, he develops a rapid tachyarrhythmia that lasts briefly. P waves are not recognizable. The atrial rhythm is impossible to identify. Therefore, neither the atrial rate nor the PR interval can be measured. the ventricular rhythm is regular, but quite rapid, at about 220 beats per minute. The QRS complexes are symmetrical, but wide and dissimilar to his usual QRS complexes. The QT interval is impossible to measure. This dysrhythmia is ventricular tachycardia. It may be tolerated by the patient if it doesn't last long, but it usually produces severe hemodynamic instability. The presence or absence of left ventricular dysfunction and the ventricular rate seem to relate to the degree of hemodynamic compromise. Ventricular tachycardia arises from an ectopic focus distal to the bifurcation of the bundle of His. It may be sustained or it may stop spontaneously. When sustained, treatment must be immediate to prevent it from progressing to ventricular fibrillation. If the rate is greater than 150 beats per minute or hypotension is present, a precordial thump is administered first, but only if the rhythm is witnessed and monitored. Otherwise, a bolus of IV lidocaine hydrochloride is administered first. Other medications which may be administered include procainamide hydrochloride, rutilium tosylate, propranolol hydrochloride, quinidine gluconate, or phenytoin sodium. Defibrillation or synchronized cardioversion may also be needed. If ventricular fibrillation develops, you'll see no recognizable P waves, QRS complexes, or T waves on the rhythm strip. The rhythm appears as a chaotic, ever-changing line of bizarre fibrillatory waves. Immediate defibrillation of a witnessed cardiac arrest is recommended. In other situations, cardiopulmonary resuscitation, or CPR, should be started immediately and continued until defibrillation can be performed. Irreversible brain damage can occur in 4 to 5 minutes if CPR is not started.
During this program, you have learned to identify selected atrial and ventricular dysrhythmias and to interpret more complex EKG rhythm strips. You have also learned which dysrhythmias are life-threatening and what the appropriate interventions are for each dysrhythmia discussed in this program. With these skills, you'll be able to act knowledgeably, confidently, and appropriately when a patient develops a dysrhythmia.